Welcome to Education Protocol Internal Medicine Series. The topic of the day is hepatocellular carcinoma. Before going to that, we will have a brief knowledge about liver tumors. When we talking about liver tumors, we can classify into primary tumors and secondary tumors. Secondary tumors are metastatic liver tumors. Primary tumors, further we can classify into primary carcinoma, the ones malignant and benign tumors of the liver. Talking about secondary liver tumors, they are metastases. The most common liver tumors among all. Metastasis can be happen from GI tract, breast and bronchus mainly, and usually multiple nodules can be seen. When talking about primary tumors of the liver, can be benign or malignant, but most commonly they are malignant. These are the main four types of primary tumors of the liver. We can further classify them into malignant carcinoma and benign carcinoma. Malignant carcinomas are hepatocellular carcinoma, the topic of the day, and cholangiocarcinoma. Benign tumors can be hemangioma and hepatic adenomas. They are very rare. 90% of primary carcinoma of liver are hepatocellular carcinomas, and 10% origin from bile duct epithelium. We call them cholangiocarcinomas. So here is the page from Kumar and Clark edition 9. You can read it leisurely after the video. Now we are going to talk about the hepatocellular carcinoma. When talking about the epidemiology, it has a significant geographic distribution. Incidence, the fifth most common cancer worldwide. And also it ranked third of all malignant tumors in Japan and China. The ratio is 3 to 4 is to 1 in China and also worldwide. When talking about the etiology, viral hepatitis is the most common etiology. It can be HBV, hepatitis B virus, and hepatitis C virus. And cirrhosis, alcoholic or non-alcoholic steatohepatitis cirrhosis. Toxins like aflatoxins also can cause hepatocellular carcinoma, and several inherited disorders can cause hepatocellular carcinoma. Pathogenesis of HBV into hepatocellular carcinoma is like this. HBV is a DNA virus. So the viral DNA integrate into our hepatocytes DNA, the host DNA. Then rearrangements in the formation of cellular sequence can be happen. Instability of host DNA in different distant sites can be happen. Distress the tumor suppressor genes. Impairment of gene repair system. Because of all these things, HCC can origin from hepatitis B virus. When talking about the pathogenesis of HCV, pathogenesis from HCV is a RNA virus. Unlike HBV, cirrhosis is always present in HCV. We call that cirrhotic pathway, and the risk of HCC is higher than in HBV. If you quote HCV, the risk is higher to become a hepatocellular carcinoma than HBV infection. HCV acts as a direct and indirect carcinogen. It induces chronic inflammation in hepatocytes, and the effects of cytokine in the development of fibrosis is main cause of hepatocellular carcinoma, pathogenesis, and also liver cell proliferation. When talking about pathogenesis of cirrhosis, HCC, hepatocellular carcinoma, frequently coexist with cirrhosis, alcoholic cirrhosis or non-alcoholic fatty liver disease associated cirrhosis. Role of the cirrhosis is to promote hepatocellular carcinogenesis. And also you must remember these risk factors for HCC in cirrhotic patients are male sex and age and duration of cirrhosis. Pathogenesis from toxins like aflatoxin is like this. Aflatoxin B1 is derived from Aspergillus flavis fungus. We can see that in certain geographical regions, just like South Asia, because of consuming a lot of dry foods like dry chili and some grains, the prevalence of aflatoxin intoxication is high in South Asia. Exposure to aflatoxin B1 specifically inactivate point mutation in the p53 tumor suppressor gene, so it induces hepatocellular carcinoma. Now we are moving to the pathology of HCC. When talking about the gross appearance of HCC, we can classify it into three categories: massive HCC, nodular HCC, and diffuse type HCC. Massive HCC, the prevalence is most common in China. The size and shape is large circumscribed mass over 5 cm with small satellite nodules. Most common in the non-cirrhotic liver in younger patients. Complication: most prone to rupture because this is very large. It can be ruptured. If it is ruptured, it's an emergency. And also masses over 10 cm, we call that giant massive HCC. Remember, it's more common in China and mostly associated with non-cirrhotic liver in younger patients. So the cause for massive HCC is mostly hepatitis B virus. Nodular HCC is the prevalence is 75% of HCC in the Western countries. See the contrast of these two. And numerous round irregular nodules in various sizes. Remember this because various sizes, it differ from diffuse type, because nodular HCC is also kindly diffused, but the sizes are various. In diffuse types, it's minute tumor nodules diffusely scattered around the liver. Usually, nodular HCC usually coexists with cirrhosis, mostly hepatitis C and alcoholic cirrhosis like that. Minute HCC, diameter of a single nodule is less than 3 cm. We call minute HCC. Diffuse type is a very rare type HCC, liver infiltrated by indistinct minute tumor nodules, and The complication is difficult to diagnose, distinguish from regenerative nodules in cirrhosis. We had to identify hepatocellular carcinoma from cirrhosis because this is a malignant condition. This is the gross appearance. As I told you, this part, you can see my cursor, this whole part is a massive HCC. This red part is the normal liver. This part is massive HCC. And this one, nodular HCC, different size nodules scattered all over the liver. This is diffuse HCC, minute nodules all around the liver. Okay.